It's great to be here. I'll go straight in. So what I'm going to talk about is putting evidence together in an epidemiological context. This is my outline, which I won't read through. It's just to make me remember what to say. But I'm going to start by just saying, why triangulation of evidence in observational epidemiology or etiological epidemiology. What's wrong with the standard methods, the standard epidemiological approach, and I guess one can go back quite a long time to say what is wrong with the standard epidemiological approach, and it's something which has not improved in 30 odd years, which is that many findings have failed to deliver when they are attempted to be tested in experimental studies. An example of an influential finding was one that was published in two back-to-back papers in the New England Journal of Medicine in 1993. These studies used two different cohorts, one of male health professionals, one of female nurses that had the same instruments administered to them, and they asked people whether they were taking vitamin E supplements. So this means whether taking supplements containing vitamin E. This means whether people were putting a supplement into their hand and swallowing it every day. That was the thing that was being investigated in an observational setting. So taking supplements was what was being investigated. And what they found out when they followed people up was that the people who were taking the supplements had a dramatic 35% lower risk of incident coronary heart disease. That's quite a substantial effect. And they adjusted for all the confounding factors, the usual things that they'd measured, smoking, some reports of physical activity, body mass index, etc. The factors they'd measured, they adjusted for, and the finding remained robust. And it was replicated, as I say, across the two cohorts. The two cohorts found remarkably similar effect estimates, and this got on these are in the New England Journal of Medicine, and they got on the front page of the New York Times. They moved Clinton to the sort of second place story, and it was that vitamin E greatly reduces risk of heart disease, studies suggest. So the way that this is communicated is that this is a causal effect. This is reducing the risk of heart disease. Now, people aren't stupid, so they also did an analysis by time, and they found that once you were taking supplements for 2 to 4 years on, you've got the sort of full benefit after you've been taking them for 2 to 4 years. So this sounds great. You just have to take these supplements, and they cost very little. You just take one every day, and you get 35% lower risk of heart disease. That sounds pretty good. So people started taking vitamin E supplements in the US. And at one point, nearly 50% of adults were taking a supplement that contained vitamin E. The groups involved in the studies were, of course, interested in health. As I say, they were nurses, and there were male health professionals, and they started taking supplements more. They just after the 1993 publication, that supplement use just zoomed up to sort of half amongst that's in the nurses study, and then the even higher levels actually in the male health professional study. So this is great. We all do research because we want to have impact. This really had impact. A large number of people started taking vitamin E supplements because of your research. That's great. That's truly impactful research. Only one slight downside was when they actually did randomized controlled trials of taking vitamin E supplements for many years. In some cases, this was a meta-analysis of the trials done until 2004. There's absolutely no effect on coronary heart disease. Now, so the trials that carried on and eventually stopped because it was realized it's futile, and the estimate around the null is highly precise estimate. So the important thing here is that what you're testing in the trial is exactly the same exposure as is being studied observation. It is putting the supplement in your mouth and swallowing it. That's what's done in the randomized trial. That is what's randomized. And what was studied observationally was taking the tablet. Now, people, this is an educated cohorts. They were following the health literature. The taking leveled off as the first small trial started to appear. And then as the large trials started to appear, showing that this was utterly futile, the taking it fell away. Now you might say, oh, well, okay, so this is useless research and people paid a bit and spent a bit of money on vitamin E supplements. But if you're taking a vitamin E supplement that you think is reducing your risk of heart disease by 35%, you might take less care about stopping smoking or about taking a cholesterol lowering drug or about exercising or maintaining weight because you're doing something you think protects. So these sorts of findings can be harmful when they're taken up by the population. I say both cohorts showed the same take-up. Now, the findings were reported in talks, and these get publicized, of course, by the researchers. When they reported the vitamin E findings, they also reported protective effects for beta carotene. But these actually slightly larger. But these never appeared in the New England Journal of Medicine. In fact, these never appeared anywhere. They were never published outside of the abstract. But they still got publicized. And amongst the study cohort, people started taking beta carotene supplements. But you'll notice the beta carotene supplements fell off rather sooner. They fell off rather sooner because in 1994, the first beta carotene trial, the ATBC, appeared showing higher mortality, not robustly, but if anything, higher mortality in people taking beta carotene, and the either no or worse outcomes have continued to be seen in the later trials. So now these were done in well done epidemiological studies being done in the ways that such studies were done, and they were replicated. But the results were just wrong. And this was just played out again and again in epidemiology with other nutritional supplements, folate, vitamin A, etc., with hormone replacement therapy, with many other things. So what I'm going to suggest is that just replication of the same study designs doesn't actually increase your confidence in the findings. But very rapidly, the volume of data generated by similarly biased sources, because the studies done in similar contexts, in high-income context, in high-income countries, will have the same sorts of confounding structures. The people taking the vitamin E supplements will have better health, better health-related behaviors, etc. The same confounding will exist. So such data from the same study designs rapidly asymptotes down. These are the beta carotene findings that Matthias Egger and I meta-analyzed from the observational studies and from the trials in the mid to late 1990s. You show the cohort studies, beautifully replicated findings of apparent protection, lower risk, substantially lower risk in the cohort studies, but if anything, adverse effects in the randomized controlled trials. So you can see these findings are not neutral. These findings can be obviously be damaging if promulgated, including because they just lead to sort of distrust in findings from epidemiological data. An interesting phenomenon, very interesting phenomenon, is that remarkably, and it's truly remarkable, after the trials appeared, no more cohort studies dried up. People didn't carry on publishing cohort studies showing that beta carotene apparently leads to a big reduction in coronary heart disease risk, cardiovascular risk. because they'd seen the trials. Of course, the studies carried on showing that, they just don't get published because, of course, there's a publication bias. And even a few studies started appearing, suggesting that the effects, those effects weren't seen using different analytical approaches when the answer was known. But even that, when thinking, from in the observational context, that could be easily explained by different analytical, the way people can choose different analytical approaches when applying them to the same data set. There's an interesting paper in PNAS a couple of years ago when 73 different research groups were given precisely the same data set. This was in a sociological hypothesis testing framework, where the hypothesis was actually about migration and trust in societies, but they were given the same data set, and they were basically told the question that they were supposed to address, and that was it. They were then told to go away, analyze the data, and produce a report on the data. And what was found was, again, rather remarkably, is that 25% of the studies found a apparently statistically significant, statistical significant, saying statistically significant is banned in Bristol, but I'll use it because that's how the study reported it. 25% found a statistically significant result in one direction, 17% found a statistically significant result in the other direction, and 58% reported a finding that wasn't significant in either direction. But this is the same data set being observational data set being analysed by different research teams, coming up with opposite answers. So there's not much constraint really on what you can get when analysing observational data. So the variety of evidence thesis would suggest that it's the variety of evidence, which means that the use of different methods which make different assumptions, that actually provides more evidence on your hypothesis. Just replicating the same study design, same analytical approach, doesn't actually greatly add to the evidence beyond a pretty low threshold of data. So you need a variety of evidence, a planned variety of evidence, rather than replication. And you can apply, and I'll discuss this later in more detail, intuitive and also formal reasoning about the independence of the direction and the magnitude of the anticipated biases that might exist in those different study designs. And finally, something I'll talk rather little about is that if you can establish mechanisms that link the exposure to the outcome, then establishing mechanisms does provide additional data. And quantification is sometimes useful, but there's many beautiful examples in epidemiological science where quantification wasn't necessary. An absolutely brilliant document is Theobald Smith's investigation of cattle fever from the end of the 19th century, where there's no quantification whatsoever, but there's a totally convincing report on the causation of that disease. So I'm just going to give a few examples of what I'm meaning by varieties of evidence in ecological epidemiology. This isn't comprehensive in any way. There's many more, but I'll just run through a few. There's conventional observational studies. Now, the issue with conventional observational studies is that it requires the no unmeasured confounding and the no measurement error assumptions. If you have those two assumptions, if there's literally no unmeasured confounding and everything is absolutely perfectly measured, you can argue that you could get a meaningful estimate out of that, causal estimate out of that. But the equation is that no unmeasured confounding and no measurement error means you're not looking at epidemiological data, because there's no epidemiological data set that has neither of those. And there's various flavors of analyzing observational study results that attempt to do it better, that are making serious attempts to do it better, but there's no magic formula for such. All changes in attempting to get causal inference from observational data trades off one assumption with another assumption. You can relax one assumption, but that always requires an additional assumption to be made. There's no free lunch. You know, and calling approaches real world evidence doesn't actually make them evidence. It's a great idea, label it evidence, and people sort of think it's evidence, but in many situations, you're not actually producing particularly useful evidence about causality. So as a quite, relatively simple approach when you think you've got a confounded observation would be to say, we're not going to replicate this in the same circumstances. What we're going to do is deliberately go out and choose a context in which the confounding would be expected to be different. Go in a different direction, for example. And then those studies in different contexts would provide some evidence regarding your hypothesis. So an example of that would be on breastfeeding and the outcomes of breastfeeding. So in high-income countries, breastfeeding relates to virtually everything which is good. So observationally, breastfeeding, relates to lower infections in infancy. It relates to less obesity when older. It relates to better cognitive ability, better respiratory function, etc. Everything good. In the AUSBAC study, being breastfed, that's a birth cohort in Bristol, being breastfed led to you getting larger, more expensive Christmas presents. You did exactly the same analysis as you do with breastfeeding and child with obesity, and you get that being breastfed causes you to get larger presents. Because of course, breastfeeding is very strongly socially patterned. Better off families are more likely, kids are more likely to be breastfed. And I think before this work was done, a meta-analysis was done of a large number of studies, approaching 100 studies in high-income countries, and they all sort of showed the same thing. Breastfeeding, you had lower blood pressure, less obesity, everything was better in the breastfed kids. But all of those studies were in high-income countries, and the confounding was the same. So Mary Jo Brian went off, moved to Pelotas in the south of Brazil, where there was the birth cohorts had been set up in a very different context in Pelotas. And in Pelotas, breastfeeding was not confounded in the same way by socioeconomic position. So this is breastfeeding at 3 months according to family income. And in AUSBAC, you see a strong association. In Pelotas, there was essentially no meaningful association of income and breastfeeding. And these are just 4 other socioeconomic measures, all of which showed little association in Pelotas, but a huge association in AUSBAC. So the confounding structure was clearly different in AUSBAC and Pelotas. You were not getting the same confounding. And looking at between AUSBAC and Pelotas at 2 blood pressure outcomes, systolic and diastolic blood pressure at BMI and at cognitive ability, what was seen was that being breastfed was related to lower blood pressure and lower BMI. In Pelotas, with much less social patterning, the effects were not seen either to the same extent or in the same direction, except for the cognitive ability. In a group of cohorts in low and middle income countries, which gave a more statistical precision, the association with blood pressure and BMI was not seen in the way it was seen in AUSBAC. And there was a clear heterogeneity between AUSBAC and the low and middle income country cohorts. These cohorts didn't have cognitive ability measured there. So there's been one large randomized trial, probably the only one that maybe will ever be done, of breastfeeding, which was carried out in Belarus. Which was the country with very low breastfeeding rates, so around 5%. or less at 3 months when the study was done by Mike Kramer. And they cluster randomized hospitals to have breastfeeding promotion or not. They had a very substantial effect on breastfeeding, increasing it to around 40% at 3 months in the intervention group. And in that study, Richard Martin was involved then in the follow-up of that study at an older age. And in the trial, there was no effect was seen on blood pressure or BMI, but there was some hint, there was some benefit in cognitive ability. So there, what you're doing there is deliberately going out and getting a situation where the confounding structure would not be the same as it is in the main studies that you are doing. Now, the contexts don't have to be geographical context. The context can be time, because very often over time, the confounding structures will change. This is a recent study on eating fried food and all-cause cardiovascular cancer mortality. You can guess what the answer would be. This is in the US. Fried food is lethal. Fried food, eating lots of fried food. And it's always slightly suspicious when everything makes everything worse, because biology doesn't tend to work like that. We don't have like some sort of miasma where we change one thing and it influences everything badly. You tend to see specificity and disease associations. But that's what you see now in the US. Fried food is bad for you. And I'm now going to show you my very favorite. This is my favorite epidemiological finding of all time. It's hidden away amongst the huge number of additional tables presented with the Hammond and Horn study set up in the 1950s, looking at smoking and mortality. And hidden away there is the fried food results in at that time. And what you show here is that it's impossible to eat too much fried food. You just carry on eating fried food and your mortality rate just zooms down. If you're eating it 15 times a week, that means you're having not just lunch and dinner, but you're having a fried breakfast as well. That's your lowest mortality. Because of course, fried food then, steak, fried food at that time was not something that was considered bad, something that the poor were doing. And there you get the exact opposite, but very, strong, robust statistical findings that fried food is related to lower mortality. So that at least makes one think about the sort of whether frying is particularly bad in itself. So those are cross-context comparisons when you deliberately plan to do your study in a situation where the confounding would be different. Another approach would be using negative controls that would be taking either an outcome or an exposure that was implausibly related either to your exposure or outcome, the one that you're looking at. So if you've got an exposure, you look at a negative control outcome. If you're looking at exposure and one outcome. And 30 odd years ago, there was a lot of publications about smoking and suicide, that heavier smoking was associated with a higher risk of suicide. And of course, this is sort of biologically plausible. The papers would finish with a discussion that would talk about serotonin, how smoking influenced brain serotonin levels. But there's other hypotheses, such as the fact that if you're depressed, you find it difficult to stop smoking, and smoking is sort of self-medication for forms of misery. So we looked at, this being the US and the study being large, we could look at the very obvious negative control outcome, which would be confounded in the same sorts of ways of smoking, but was not a plausible outcome of smoking, and that is being murdered. And in the US, smoking predicts your risk of being murdered in the same way as it predicts your risk of committing suicide. Now, the only plausible hypothesis I can think of for smoking and being murdered is that the paramilitary wing of health promotion or health education agencies are actually shooting smokers as the ultimate deterrent. Otherwise, I can't think of any sort of plausible way in which smoking can lead to you being murdered. Here's the current sort of fad in nutritional epidemiology is ultra-processed food, which just happens to be the food which the poor folk with the least social and economic resources eat. People who don't have time to prepare meals for the kids because they both have to work full time, actually getting just enough money to feed the kids. That is, of course, related to everything bad. And there's been quite a lot of studies of ultra-processed food consumption and head and neck cancer, which we, in a big collaboration, the EPIC study is also putting together some other studies, the European Perspective Investigation of Cancer and Nutrition, sort of replicated this fact that ultra-processed food consumption is indeed associated with head and neck cancer, but it's also associated with dying in accidental death, which isn't really a plausible hypothesis about how ultra-processed food can lead to that. So negative control outcomes in this situation would cast some doubt on the, or will make you want to at least caveat what you said about the associations of the exposure with the outcome. And you can also use negative control exposures, which will be an exposure which is confounded in the same way as the exposure under investigation, but was not a plausible cause of the outcome. And just in the way that breastfeeding is associated with everything good, maternal smoking during pregnancy is associated with every single bad outcome one can imagine. And of course, smoking during pregnancy has effects. Here is the smoking during pregnancy and the outcome. If the mothers smoke, you have a very obvious negative control in the situation where you're looking at the intrauterine exposure to what smoking produces in the mums, is that the dad's smoking will be confounded in the same way as the mother's smoking. It will be related to the same confounding factors, and the pattern is very similar, but it is not a plausible cause of the intrauterine insult leading to lower birth weight. And when you see that then conditional on the mother's smoking because there is assortative mating by smoking behavior, the father's smoking isn't related to lower birth weight. So this is when something that is a cause, this is what it looks like when it is a cause. Smoking in pregnancy has also been associated with higher obesity in the offspring. But of course, there's many confounding factors, and socioeconomically patterned confounding factors would generate the same association. And you see a pretty similar association if it's the mother smoking or if it's the father smoking, which suggests at the very least that you're heavily overestimating the actual causal effect of intrauterine exposure to smoking amongst the mums. So I think negative control outcomes and negative control exposures both have quite considerable power in epidemiological studies, and are, in my view, underutilized. Other approaches, other varieties of evidence, ways to sort of try and deal with confounding to an extent, would be by doing analyses within SIBShips. So that would, within SIBShips, if you've got family level confounders, then those confounders shouldn't be seen if you have siblings who've experienced the same confounding. Or you have you utilize external perturbations which will change the exposure, but you can't think of how it'll change the outcome except through changing the exposure. An example of that would be use of age and the coronary artery bypass grafting and the subsequent mortality of people after they've received coronary artery bypass grafting. For this regression displacement, you use the fact that guidelines you focus on about the age of 80 as the age at which the intensity of trying to implement coronary artery bypass grafting changes. And here what you can do is you can look at the people who entered the emergency room in a situation when they would be considered for coronary artery bypass graft if they were 2 weeks before their 80th birthday or 2 weeks after or 2 weeks after that, compared to the same 2 weeks before and 2 weeks after at other ages. Included, so the guideline age is 80. At other ages, you see very little. You don't see any. You see very little systematic difference. But at 80, you see that a much higher percentage of the people who were 2 weeks before their birthday were getting grafts than 2 weeks after their birthday, and that translated into lower mortality in that group. So the clear lesson of this is, none of you are even approaching this age, but I am obviously. The difference is that when I do get to that age, when I get admitted, I will lie about my age. I will make sure that I say that I'm young. I report that I haven't yet hit my 80th birthday if you want to get better care. But it's a way of you can use those regression displacements to get some estimate of the effect. Now, yesterday I talked for too long, but I talked about Mendelian randomization at some length, and I haven't got the time to talk about Mendelian randomization here, but I do have a 2-minute animation which I might be able to play. Ooh. I can't actually. I'm blind. I can't actually. Oh, I can't actually see the. How do I get it? Oh, there it is. Yeah. Brilliant.
Epidemiologists are interested in understanding factors related to health and disease. Do smokers tend to die younger than non-smokers? Certainly looks that way. But disentangling cause and effect can be difficult. Smokers are different on average from non-smokers. They're more likely to drink heavily and have less healthy diets. But even if we measure these confounding factors, we may not measure them perfectly. Or there may be others we haven't measured. Also, as people become ill, they may cut down and give up smoking, which could wrongly suggest that reduced smoking leads to worse health. We could randomly assign 50,000 people to smoke and 50,000 people to not smoke and follow them up to monitor their health. This removes the possibility that any other factor could be responsible for any differences we see in their long-term health. But this is neither ethical nor practical. Fortunately, we've all been recruited into an experiment without knowing it at the point at which we were conceived. Our genes, which are passed on early from generation to generation, influence how much we eat, sleep, drink, smoke, and more. These genetic influences are not affected by anything else we may or may not choose to do in life. They're not related to confounding factors. We can use this knowledge to learn about cause and effect, grouping people according to their genetic code. This method is called Mendelian randomization. For example, smokers who carry one version of the gene called CHRNA5 tend to smoke less heavily than those who carry a different version. When we group people according to which version of this gene they have, we find that the people with the version of the gene associated with heavier smoking do indeed die younger. But is the gene influencing how long we live in some other way? We don't think so. When we look at the same gene in non-smokers, there's no effect on life expectancy. So the effect must be driven by smoking. Using this method, we can show that smoking causes lung cancer, heart and respiratory disease, and many other diseases, but does not seem to influence depression or anxiety. Mendelian randomization has already begun to tell us about factors that influence our risk of disease. Now we're using the same approach in other ways, to look at several risk factors together, and to look at what influences disease progression, may help us to develop new treatments.
That's you now all understand Mendelian randomization perfectly, and
again on that.
Oh, I see. Where are we? I will learn that. So it's not just that I'm lazy and can't speak that fast when I'm actually talking. It's that every time that's watched on with a new IP address, it clicks up another watch. And I'm approaching the magic 100,000 when I get about a cent from YouTube. But my aim to become a YouTube billionaire is dependent upon this. So when you go home, please watch it again. Every time you're on a new IP address, just watch it. Get your kids to watch it. and you'll definitely understand Mendelian randomization after watching it lots of times. The Mendelian randomization way of using genetic variants as a quasi-randomized instrument for understanding phenotypic causes. And an example we give there's a negative control combined with Mendelian randomization, because you're looking at the genetic variant of people who don't smoke. It can't be related, who've never smoked, it can't be related to heaviness of smoking in them, and you don't show any association with the gene with the outcome in that group, but you do see a relationship between the gene and the outcome in the group who've ever smoked. So you've got a combination there of Mendelian randomization and negative control. You can use genetics to understand confounding. I mean, when you get repeatedly, you get very strong observational effects that replicate and replicate and replicate. There must, underlying that must be some causes. You know, there must be some confounding as a causal concept. And if you understand what those causes are that generate that association, then that can, you know, contribute to causal discovery. An example here is HDL. Small HDL particles really quite strongly predict risk of death when you've got sepsis. So if you have low small HDL, that's SEPTA1, and you have lower risk of death with sepsis, quite substantial. If you have higher small HDL levels. But if you do Mendelian randomization, it doesn't look as though it's the small HDL, doesn't look causal. But you can show that interleukin-6 activity relates both to lower small HDL particle level, and it relates to higher sepsis mortality. So part of the observational association is driven by that causal factor. So you can use genetic data and Mendelian randomization principles to understand confounding, and also to estimate the extent to which confounding should exist. As well as in Mendelian randomization, in many implementations, you're using the genetic variants as instrumental variables, something which isn't confounded, shouldn't have an association with the outcome except through the exposure of interest. There are, of course, other forms of social changes, changes in laws, for example, and that can be used in that way. And tax rates on smoking has been used in different states in the US, for example, and when there's changes in that, smoking rates change in the states. So there's lots of non-genetic such instruments, and obviously randomized controlled trials can be used in some circumstances when they're applicable. And I mean, what I talked about use of negative controls with maternal smoking and birth weight of offspring. Now, this is a very obvious causal effect of maternal smoking during pregnancy on birth weight of offspring. And all these different study designs have been used in that situation. They all point in the same way. And there's a sort of a particularly useful study design is children of monozygotic twins, when one monozygotic twin smokes and the other doesn't. So you get matching on perfect matching on genetics, and a fair degree of matching on certainly on childhood social circumstances, etc. And you show the same association as you show in all the other studies. So that's a sort of example of something seen in observational epidemiology, which triangulates very well across a wide range of different study types. So the key thing with the variety of evidence thesis is it's not worth going out and getting, as I say, the data that are confounded in the same direction or the same way. So you need to think that you're using study approaches for which the bias will be acting optimally, for example, in opposite directions, and would be expected to have different magnitudes of effect. In principle, and if you had a sort of large sample of studies of different types, you could sort of formally explore this with a mediation analysis, in which the effects you would have some effects that would be seen through the exposure you're looking at, but then you would hope that you would look for the fact that the direction and magnitude of the effects net of taking out the exposure of interest differ, different direction, magnitude, etc. But there's not really situations where there are enough data to do that. I mean, in a triangulation of evidence framework, you would always want to think of what you are estimating, or your estimand, which will be familiar to you. You might want to scale estimands, because your estimands might have some sort of logical quantitative scaling. An example there would be combining Mendelian randomization with RCTs, when in the Mendelian randomization studies, your genetic variants relate to differences in cholesterol level right the way across life, which obviously would have a larger effect on coronary heart disease risk, seeing as atherosclerosis is a cumulative process, which starts in adolescence, versus the randomized controlled trials, where you're only given treatments for 5 years, say, and in the randomized trials, you get about 35% of the effect that you would see. So your estimand in your randomized trials is 5 years of treatment in middle age. Your estimand in Mendelian randomization would be a lifetime difference in cholesterol level. And then if you can scale the estimands, you can combine across study type, but obviously you would look for within and between study type variation. It's particularly powerful if you combine methods. I just mentioned RCTs and Mendelian randomization. You could combine Mendelian randomization and regression discontinuity analysis. These are findings from 2 analyses applied within UK Biobank. One is a Mendelian randomization approach. There are genetic variation that relates to educational attainment. You can estimate the effect of educational attainment through MR, and you can also estimate the effects of educational attainment through the fact that there was a change in the law, which happened during the times that across the range of birth cohorts that entered UK Biobank, where children could have left school at 15, and then they were not allowed to leave school at 15. That change in the law produced quite a large increase in total number of education years people had across a single year, because there were a lot of kids left at 15. They didn't leave at 15. Some of those who would stay on to 16 would, of course, then stay on. They'd discover they didn't hate it and would stay on for longer, get qualifications, etc. And basically, the 2 approaches, they both estimate larger effects than the observational effects, which is what you expect, because instrumental variables analysis, regression discontinuity, automatically corrects for measurement error. You can combine Mendelian randomization and negative control outcomes. This is something I showed yesterday, which was of a non-linear Mendelian randomization approach to looking at body mass index and all-cause mortality, suggesting the sort of J-shaped curve. But if you use it as a negative control, you use precisely the same method, and you look at an impossible outcome, or impossible outcomes, which are sex, chromosomal sex, and age. Clearly, your body mass index cannot change your chromosomal sex or your age, but if you carried out those analyses with these negative controls, you got these sort of nonsensical findings, which would generate the J-shaped curve that you saw because of the higher mortality associated with male chromosomal sex and being older. So those are ways the negative control then throws doubt on the Mendelian randomization analysis in that situation, and positive controls as well. You can combine target trials with genetics to understand confounding. There's people here will probably know this paper, target trial approach applied to antihypertensive drugs and to statins. And in the study, the results are reported for the antihypertensive drugs alone and the combination of antihypertensive drugs. For statins alone, which matched the trials, and for the combination of statins and antihypertensive drugs, which sort of matched the trials. the conclusion was that randomized trials are not available or feasible observational analyses can emulate a variety of target trials. But in the conclusions, not presented in the results, in the conclusions, it's reported that the target trial suggested that antihypertensives were causing a 12% increase risk of death, which randomized controlled trials show is the opposite of the truth. People here work on the benchmarking of observational methods comparing randomized trials, which says, you should relate target trials to the outcomes seen in randomized controlled trials, and benchmarking is particularly valuable. It was suggested in an editorial that maybe the reason for the sort of antihypertensives not working well is that they're used almost exclusively by people with risk factors for the outcome, which cardiovascular disease. But if you look at, for example, at the genetic risk of people who end up taking antihypertensives and taking statins, they're similar, but rather reassuringly that doctors are doing what they should do. You see that for the coronary heart disease genetic score, this is the polygenic score that produces that relates to coronary heart disease risk. If you've got a higher coronary heart disease score, you're more likely to get on statins and antihypertensives, but a bit more likely to get on statins than the antihypertensives. If you've got increased genetic risk of stroke, you're more likely to get statins or antihypertensives, but this time it's slightly greater risk for greater chance of getting antihypertensives, which is good news because antihypertensives are particularly important for lowering blood pressure, which is related particularly to stroke, and LDL cholesterol related to coronary heart disease. So it doesn't seem that that notion is underlying the difference. Now, I mean, a lot of evidence that relates potentially modifiable risk factors to disease outcomes would be sort of, you often see in discussion, like I talked about with the smoking, serotonin might go up. And of course, it is very useful if you have evidence of the mechanisms that link these things from animal studies, cell systems, etc. Lots of that evidence exists. But I mean, the notion of biological plausibility is quite a sort of slippery notion, because often it's just introduced in the discussion stage of the paper. The results are then linked to what is biologically plausible, and then it's said that supports what you've seen. So back in the late 80s, early 90s, I mainly worked on HIV, and I was at the London School of Hygiene, and I was working on looking at the use of oral contraceptives and HIV transmission, and I was in those days. It's difficult to imagine this world existed like this, but you actually went to the library and you looked at the journals that had arrived, the physical copies as they'd arrived. And here in 1 week in 1991, there was a study of cofactors in male to female sexual transmission of HIV. And this study found that oral contraceptive use increases the risk of future HIV infection. And then in the discussion, it says, direct effect. That oral contraceptives have a direct effect on the genital mucosa, making it a less successful barrier to HIV, and that often you get more than one, and also it's immunosuppressive action, which would increase susceptibility to HIV. And I thought, yeah, that sounds plausible. Then I went and picked up the issue of a different journal. This was in the Journal of Infectious Disease. I picked up the Archives of Internal Medicine, and there happened to be a paper on the same issue. In the issue current issue on the same thing, but that found the opposite. That found a lower risk of HIV transmission with the oral contraceptive. And there in the discussion they say progesterone-containing oral contraceptives thicken cervical mucus, which might be expected to hamper the entry of HIV into the uterine cavity. And that sounds equally plausible. And of course, you can find evidence to support whatever you find. I used to set when I was teaching at the School of Hygiene around this time, I used to set a task of giving different groups the sort of different answers to go and get the evidence supporting it. There are ways of possibly formalizing this. If you're doing a pre-registered study, you could actually get experts, and you could elicit the priors of experts in those biological disciplines, what they think is plausible and plausible regarding mechanisms in advance and elicit those priors before you actually carry out the study. It's been done in other areas, particularly climate science, but I've not known it be used so far in epidemiology. So I'll sort of finish by saying that I think this triangulation of evidence approach is similar to sort of solving crosswords, and this is from Susan Hack via Paul Rosenbaum, and they give this sort of crossword analogy. And the important thing about the crossword analogy is the notion that in this way is that things which are actually a bit orthogonal to the question that you're asking, they can actually provide evidence by supporting the scaffolding, supporting the lines of evidence that you're generating for the particular question. So, if you imagine you've got a crossword, you've got the convoluted, you're trying to answer the question convoluted, and there's lots of 8-letter words that mean convoluted, involved, confused, puzzling, tortuous, involute, baffling. So you've got no idea what to put there. But then if you look at one across, you've got A and O, for instance. Lots of medical people here. What do you think A and O could be? Sorry? I think you're right. Someone said something. What did you say? Yeah, well, it's blood group or blood type. It could be blood type, but it couldn't actually because type's too few letters. But blood group. So that seems reasonable. And then one that even I could get is got Gangster's Girlfriend. I watch a lot of film noir. That's a mole. And then one that I doubt anyone here would get. There are some people from the north of England, but one that if you know it, you know it, which is besom. Anyone any idea what a besom is? If you're from a certain part of north of England, you know that that's a broom. So that's still not really. That's getting you down to confused or tortuous. And then you've got discharge of water, and that would be outflow. So that then gives you the answer. The sort of crossword, the scaffolding provides support for your answer, but blood group and mole provide support as well. So if you've got evidence which actually supports the method, it supports the method in the particular set where you're working on that, even though that might not intersect with the answer you're trying to get, that provides support for the way you get the answer that is correct. And I'd recommend 2 fantastic books by Paul Rosenbaum, Observation and Experiment, if you're interested in ways of practically doing studies with causal, try to get causal answers to epidemiological questions, or his recent replication evidence factors. But as I say, I nicked the crossword analogy from him. I think triangulation is rather overlaps with the Bradford Hill viewpoints. Bradford Hill never called them criteria. He always said that they were just ways of, you put them all together, that actually allowed you to have some better statement about the evidence. But I'll finish definitely on the role of protocol development, because it's clear that if you have a strong hypothesis and you go out and you look at different approaches, you might find different approaches that support the hypothesis, but that has obvious problems. I mean, the problems were demonstrated when the National Heart and Lung and Blood Institute made it compulsory that reports of trials were produced, even if they weren't published. They were given to the NHLBI if they had funded them, and that they would then publish, put them on their website. And when that happened, what you see here is you had before that happened, then there's a lot of studies with benefit, rather fewer studies that were null, and no studies that demonstrated robust harm. And that remarkably, when that reporting was brought in, when that reporting was brought in, suddenly you got a much higher ratio of null to beneficial studies, and actually some showing harm appeared. So I think the protocol development, sticking to what you say and reporting what you say is important. obvious problems without protocol development, as you can sort of p-hacking, you can do a whole stack of different analyses, as I sort of showed with the PNAS example from 2022. You can hypothesize after the results are known, or harking as it's called. You can change your hypothesis when you actually see results and then say that you've triangulated evidence on that. You can have cognitive biases, i.e. you can just pick evidence that actually fits with the answer that you want to give. I talked about these, the target trials of statins, which is the sort of the pin-up of target trials, and many target trials have been done of statins, including statins in survival in patients with cancer. In this study, some people wrote in, Ahern et al. Wrote in, and they said that it was concerning that in this target trial, statins weren't associated with death from any cause, which is at odds with their well-documented beneficial effect on cardiovascular mortality. And the reply was that the best data on the all-cause mortality that matched that study was one in which there was no effect on all-cause mortality. So this was some sort of benchmarking, but against a single study. Then another target trial was done of statins, this time with colorectal cancer. And this time in this study, an effect was seen. And there, when you're looking at the same thing, which is all-cause mortality, there's either the answer's either yes or no on that. When you're benchmarking, surely the answer's got to be yes or no. But in this case, a meta-analysis was then matched what was shown was quoted. So, you know, a protocol, if you're doing a protocol with your triangulation study, that would not allow for cognitive biases, which are, you know, everyone will have them to be applied. For triangulation, the best check on the veracity of science is the availability of people to see for themselves, accessible data is essential for that. In 1994, I was asked to write an editorial for the BMJ, and I did, and I said that the BMJ should introduce making authors release their data when to get publication, and that this would lead to more reliable publications. The BMJ actually, the editor of the BMJ supported this and took it to his editorial board, and the vote was one, that was him, versus all the rest against it. But now it is something which is quite commonly seen, that you've got to make data and you've got to make code available, and pre-register a detailed protocol. I know there's an interesting topic for discussion. I know there's disagreement, but I think that pre-registration of detailed protocols would actually lead to more reliable science. And the thing about developing a protocol, which we obviously do with experts, you know, content experts in the different areas, would mean that the consensus would be about what is admissible evidence. So you'd reach consensus in advance about what forms of evidence for this question you're asking, which forms are admissible, and which ones would you aim to include in your study. You would not get consensus around results. Once you've actually got findings and you're debating the consensus, trying to get consensus around incorporating different findings, then it's clear which way they go. So one could obtain consensus around what should be admissible evidence before the findings are known. There are still potential, everything has potential limitations. You could have parking, or you could pre-register after the results are known, but that's fraud. If you do that, then you say that you're pre-registering this before you know, then that is just fraudulent, and that should be dealt with in the ways that fraud should always be dealt with. And these are the people who did all of the work, and that's if you want to know more about Mendelian randomization. There's an international conference on it in Bristol. And if you've got anyone you really dislike, but you've got to buy them a present, then I can recommend this book on combining human genetics and causal influence to understand human development, human disease and development. And that's it. Sorry I went on for so long.